Type 1 Diabetes by Mia, Esther, Lulu, and Hai. This is our group's concept map for type 1 diabetes. As you can see, we have color coded it, so each color represents a different section of what we're talking about. In the top left corner, you can see red, which we have talked about the complications of type 1 diabetes. So it might damage the kidneys, eyes, nerves, cognitive awareness, heart, and brain, which can result in hyperglycemia, hypertension, coronary heart disease, etc. For orange, we have the pathophysiology of type 1 diabetes. So the insulin producing beta cells destroy the immune system, which can lead to the hyperglycemia and hypertension and ketoacidosis. In the yellow, we have the symptoms such as high blood glucose levels, polyuria, polydipsia, polyphagia, etc. And if you have these, you should be seen by a doctor as soon as possible. In the green, we have the testing, such as blood sugar levels, but fasting blood sugar tests, oral glucose intolerance tests, etc. In the aqua, we have the risk factors such as having a family history of diabetes. In the light blue, we have how it's clinically managed by nurses and how we educate the patients on it. And on the purple, we have the medication for this disease, the insulin, and the different types of insulin. The reason we decided to color code this is so it's easier to read and understand, and also because it's summarized information, we want all the lines and all the words so your eyes are able to find what you need easier. So we summarize all that information from our slides to put it on this for an easy way to understand type 1 diabetes at a glance and to make it easy to link all the information together and understand what results in what and what this means and how it can affect the body in a bunch of different ways. But yeah, this concept map represents our PowerPoint presentation, which I will now present. Diabetes pathophysiology. Type 1 diabetes mellitus occurs when the blood glucose levels are too high, caused by the destruction of the beta cells. Beta cells are found in the pancreas and produce insulin. A cluster of beta cells is called an isolate. Insulin controls the glucose levels of the blood through enabling the cell to accept and process glucose. Glucose is the primary source of energy for every cell, and once inside the cell, it is converted to ATP. Type 1 diabetes mellitus occurs when the body is unable to recognize its own insulin-producing beta cells, and an autoimmune or idiopathic response occurs, destroying the beta cells in isolates Langerhans. Therefore, the pancreas is unable to produce insulin due to the destruction of these cells. Without insulin, glucose is unable to enter the cells and form ATP, and is left in the bloodstream. This results in hyperglycemia, which, if untreated for a long period of time, causes serious damage to the vessels that supply blood to vital organs, increasing risk of stroke, heart, and kidney disease. Due to ATP not being able to be produced, there is a shift in energy metabolism to fat and proteins. A byproduct of fat is ketones. Due to the fat cells being used more, an increase in ketones can be observed. The increased amounts of ketones can rise to unsafe levels and can be fatal. The brain is very sensitive to not having enough glucose in the cells, and communications between neurons can be interrupted due to the neurotransmitters not being produced. From this, polyphagia is observed. Furthermore, when the body is producing enough insulin, it is able to reabsorb the glucose cells through the kidneys. When there is an excess amount of glucose in the blood, the kidneys are unable to reabsorb all the glucose. The glucose that is unable to be reabsorbed passes through the kidneys and damages the nephrons and continues into the urine. Glucose pulls water with it. Therefore, the high amounts of glucose being passed to the kidney promotes osmosis in the kidneys. This leads to polyuria, which promotes polydipsia and glycosuria. Risk factors of type 1 diabetes. It is unknown what causes the autoimmune reaction that leads to the destruction of the beta cells. Therefore, a clear link between type 1 diabetes and outside factors is difficult. However, there are factors that increase the possibility of developing type 1 diabetes. These include family history, genetics, geography, and age. It is suggested that having a family history of type 1 diabetes slightly increases the chance of developing the condition. A study conducted by Americans Diabetes Association found that an individual who had a sibling that has type 1 diabetes has a 6.9% higher chance of developing the condition before the age of 16. Genetics can also be seen as a risk factor. as it is observed that type 1 diabetes is related to human leukolyte agents, or HLAs. It is suggested that individuals with certain HLA types, most commonly HLA-DR3 and HLA-DR4, are exposed to the virus that causes the autoimmune system to attack the beta cells. Continually, those living further away from the equator have an increased chance of developing the condition than those who live close. For example, in Finland, the rate of type 1 diabetes is 400 times higher than in Venezuela. Finally, diabetes is most commonly diagnosed before 40 years of age, and 50% of cases are diagnosed before the age of 15, making those who are younger at higher risk of developing the illness than those in their later years of life. Signs and symptoms of type 1 diabetes. Signs and symptoms of type 1 diabetes mellitus may be noticed over a few days to weeks in children and young adults. This may differ according to the severity and the onset of the disease. They include excessive urination, increased hunger, increased thirst, unexplained weight loss, dry mouth, blurred vision, mood changes, weakness and fatigue, bedwetting in children that have not previously, skin infection/genital sores, slow healing of injuries, and glucose in the urine. Excessive or frequent urination, polyuria, may indicate that the kidney is attempting to remove too much glucose in the blood, thereby causing the body to lose a lot of water. Large loss of water may cause excessive thirst, polydipsia, resulting in dehydration. Dehydration may cause dry mouth and itchy skin. Increased hunger may be a result of the body being unable to access enough energy from the food due to the shortage of insulin. The liver metabolizes fat for energy. This deficiency causes weight loss, weakness, and lethargy. Excess fat metabolism can cause ketone production, which is unsafe for the individual. The body mechanisms thereby excretes it to the urine, ketonuria, or the breath. People with diabetes may also experience yeast infections due to the high blood glucose levels, as yeast feeds on glucose. Continually increased blood sugar levels can cause injuries to heal slower than normal because of the effective blood flow and damage to nerves. Additionally, the increased sugar in the blood causes the osmotic pressure in the eye to change, therefore changes the shape of the eyes. This can cause short-sightedness and reading difficulty from blurred vision. Finally, skin infections as a result of bacterial thriving off high glucose in the urine. This enables genital sores, thrush, and infection. Diagnostic testing of type 1 diabetes. Fasting blood sugar test. This type of test is usually done in the morning to check the glucose levels of the blood after 8 hours of fasting without food or drink. Multiple fasting blood sugar tests at different times are needed. If the fasting blood sugar is above 7 millimoles per liter, it can be considered or recognized as diabetes. Oral glucose tolerance test, OGTT. This test is conducted with fasting blood glucose after drinking provided glucose solution, then a blood sugar test. If the blood glucose is over 11 millimoles per liter, there will be a diabetic diagnosis. Random blood sugar test. This test is done during an unspecified time. This test can be less accurate compared to the fasting and OGTT tests. Random blood glucose of 11.1 millimoles per liter is determined a diabetic diagnosis. HbA1c or glycated hemoglobin test. This test provides a summary of the blood sugar levels over a few months. It measures hemoglobin percentage, which is responsible for transporting protein into the blood cells where there is glucose. If HbA1c is 48 millimoles per mole, 6.5% or above, it will be diagnosed with diabetes. Autoantibiotic test. This test checks for the antibodies attacking the pancreatic beta cells. This test can differentiate between type 1 and type 2 diabetes. Clinical management of the patient by the healthcare team in the hospital setting. 1. HbA1c screening. An important clinical management strategy of diabetes is the diagnostic and screening process. The development of standardized identification and screening processes for the new diabetes administration, both planned and unplanned, through HbA1c screening is useful to access long-term blood glucose control. HbA1c is an approved diagnostic tool for diabetes under the Medicare Benefit Schedule and by the World Health Organization. The available evidence has also been reviewed by several associations, such as the Australian Diabetic Society, the Royal College of Pathologists of Australasia, and the Australian Association of Clinical Biochemists, which confirm that HbA1c is a recommended tool for the diagnosis of diabetes. Moreover, an added benefit is that it's a simple blood test that can be done at any time of the day, at the convenience of both the patient and the healthcare team, which does not require any fasting or any special preparation beforehand. 2. Blood glucose monitoring and control. Following this, glucose monitoring control is crucial to the diabetes care, as too much or too little glucose in the bloodstream can result in acute and chronic complications from the hyperglycemia and hypoglycemia. Blood glucose control should be optimized in diabetic patients because of its beneficial effects on the development and progression of microvascular complications. Consequently, it is important to identify those with diabetes with poor glycemic control and improve a person's experience of care with the use of blood glucose monitoring. Generally, patients on general medication and surgical wards have blood glucose target range of 5 millimoles per litre to 10 millimoles per litre. These target ranges are supported with the implementation of the networked glucose meters into inpatient care to provide automated identification of patients with unstable diabetes, high blood glucose levels, or hypoglycemia. 3. Insulin therapy for hypoglycemia. Following blood glucose monitoring, another major clinical management strategy for diabetes is the implementation of standardized practice insulin prescribed and administered guidelines in non-critical care settings. This is especially important in response to the episodes of hyperglycemia and hypoglycemia. The recommendation from the American Diabetes Association is basal or basal plus bolus correctional insulin regimen for non-critically ill hospitalized patients who have poor oral intake or both, or those who are nil by mouth. Scheduled insulin regimens using insulin analogs are recommended to manage patients with diabetes and result in glycemic control in the hospital setting to prevent hypoglycemia. In the critical care setting, continuous intravenous insulin infusion has been shown to be the best method for achieving glycemic targets. Intravenous insulin infusions should be administered based on the validated protocols that allow for the limited adjustments in the infusion rate, which accounts for the glycemic functions and insulin dose. 4. Patient education. A recommended management strategy of diabetes is to deliver patient education to diabetic patients. Structured diabetes education should be delivered in groups or individually. The recommended and goal of the hospital care team is to provide continually integrated and coordination of seamless care through primary care in the hospital settings by supporting patients with community-based services across the continuum of care. By enabling patient education, the risk of secondary complications are largely reduced and is an improvement in quality of life. Patients should be supported with self-management through the provisions of patient-oriented diabetes management plans, referral to the diabetes outpatient or chronic care services such as endocrinologists, diabetic care specialists. Integrated care for people with chronic conditions is beneficial to provide long-term management of diabetes. The medication management of type 1 diabetes. Insulin. Insulin is a vital element of the energy production in our bodies. Without insulin to compensate for the excessive glucose, patients with diabetes experience elevated BGLs, while hyperglycemia paves the way for many chronic and short-term complications. As a result, insulin is used as a medication to manage diabetes in a form of subcutaneous injections. Insulin is not available in tablet form as it gets destroyed in the stomach where it becomes unavailable. With hospital patients, insulin is usually considered in terms of basal and bolus insulin. Basal insulin's role is provided a steady level of insulin to regulate hepatic glucose output and prevent ketosis. Therefore, it should not be omitted. An example of basal insulin would be Lantus. As a long-acting analog, it begins working about 2 hours after injection and lasts up to 24 hours, which makes it ideal to provide a steady level of insulin to regulate hepatic glucose output and prevent ketosis. Bolus insulin, such as Novorapid, has the purpose of preventing hypoglycemia after a meal or correct pre-meal hypoglycemia. As a rapid-acting analog insulin, it starts working within 15 minutes, peaks early after 1 to 2 hours, and wears off after 4 to 5 hours. This is what makes them ideal to use at mealtimes, as they are used to correct or supplement basal insulin if hypoglycemia is present. As an aforementioned, an effective strategy to manage diabetes in an inpatient setting would be blood glucose monitoring, where we can help identify patients with serious risk complications such as hypoglycemia or ketoacidosis. This in turn can be managed with basal and bolus insulin. Complications of type 1 diabetes. These include macrovascular disease, including atherosclerosis, coronary heart disease, myocardial infarction, stroke, peripheral vascular disease, hypertension, microvascular disease, including eye disease, kidney disease, nerve damage, skin problems like dry skin and infection, diabetic arthropathy, ulcers, dental problems, including tooth decay, gum infections, and gum disease, cognitive issues, including decreased cognitive function and dementia, ulcers, diabetic ketoacidosis, and hypoglycemia. Atherosclerosis. 97% of people with cardiovascular disease have an abnormal amount of lipids, which correlates to atherosclerosis. Atherosclerosis is a buildup of plaques that block the blood vessel, which reduces or possibly blocks the blood vessel completely. The location of the blockage can determine the disease. If the heart coronary arteries are affected, it can lead to coronary heart disease, which can lead to heart failure. Hence, atherosclerosis can lead to stroke and peripheral vascular disease. Hypertension. Diabetes has a low level of nitrite oxide, which is a vasodilator, and a high level of endothelin 1, which is a vasoconstrictor. Also, high levels of glucose stops production of arterial endothelial cells. Hence, the blood vessels narrows and leads to hypertension. Prolonged hypertension can lead to heart failure. Microvascular disease. Continuously, hypoglycemia can damage small blood vessels, which can lead to eye disease, kidney disease, and nerve damage. It can also lead to skin problems like dry skin and infection as the blood supply is reduced. Diabetic arthropathy. Diabetes causes damage to the nerve that then causes joint destructions. This exact pathogenesis is unclear. The condition is called neuropathy, atrophy. Cognitive issues. Diabetes is associated with reduced cognitive function, with evidence of abnormal structures and functional brain, magnetic resonance imaging, MRI. Also, there is more evidence to show that diabetes leads to dementia. Ulcers. Ulcers are a wound that either never heals or takes a very long time to. It is the manifestation of both nerve damage and poor circulation. Since the nerve damage, a diabetic person cannot feel the pain, hence cannot detect irritation and pain. In addition to nerve damage, poor circulation reduces healing ability and leads to poor infection resistance. Diabetic ketoacidosis. Diabetic ketoacidosis is caused by an extreme lack of insulin and is characterized by hypoglycemia, ketosis, acidosis, and dehydration. When glucose cannot be used by insufficient insulin, the body compensates by breaking down fat. Ketone is the acid byproduct of the process. Hypoglycemia. Hypoglycemia, or low levels of blood glucose, can be caused by too much insulin administered, low carbohydrate intake, and stress. Hence, it is highlighted the importance of managing blood glucose levels. And these are our references.